Welcome to 2-Minute Anaesthesia in Critical Care. Today we're going to discuss chest drains. We'll run through what they are, when they should be used, what are the risks of using them, where they should be sited, how we place them, and then how and when we remove them. Let's get started. A chest drain or intercostal drain is a sterile, flexible tube inserted through the chest wall into the pleural cavity to remove air or fluid. It is connected to an underwater seal. The tube is typically made from PVC or silicone with multiple small holes towards the end of the tube. In adults, the size varies based on the indication and technique, i.e. surgical technique versus Seldinger. But the ranges include 8 to 40 French. The bigger the number, the bigger the drain. Larger bore drains, i.e. more than 24 French, are commonly used for draining blood that require blunt dissection. As we discussed, a chest drain can remove air or fluid. The fluid could be pleural fluid, pus, blood or chyle, or placed post-operatively following major thoracic, cardiac or gastrointestinal procedures. Insertion of an intercostal drain is usually a routine procedure. However, it is associated with complications. The National Safety Agency issued a safety alert highlighting the nature of these complications, with a 12% risk of moderate harm, 1% risk of serious harm, and also a 1% risk of death. These complications can be categorised into 4 different groups. Number 1, insertion related, i.e. damage to organs including the lung, diaphragm, liver, spleen and heart, vascular injury leading to intercostal vessel injury and therefore risk of bleeding, and either localised pain and trauma. Number 2, drain related complications, if the drain becomes blocked or kinked, if there's air leakage causing subcutaneous emphysema, or also movement of that drain. Number 3, the risk of infection, localised infection versus deeper infection, i.e. emphysema. And number 4, the risk of re-expansion pulmonary edema. Now let's discuss the procedure. Step 1, preparation. Before inserting the chest drain, confirm the indication, review imaging and obtain consent, explaining the risks and benefits. Now position the patient. The patient is usually lying flat or at 45 degrees with their hand behind their head or abducted to 90 degrees. You should mark the skin with a surgical marker. The most common cause of serious complication relates to inappropriate site identification. The safety triangle for insertion is as follows. Anterior, the lateral edge of pec major. Posterior border, the lateral edge of latissimus dorsi. The inferior border runs alongside the 5th intercostal space. And the superior border is the base of the axilla. The site should then be confirmed with ultrasound. Then prepare your surgical equipment, the chest drain. And finally, the intercostal drain bottle. The optimal level is usually around 2 centimeters above the tube tip, allowing air and fluid to escape while preventing backflow whilst maintaining a negative pressure, enabling lung re-expansion and maintaining respiratory function. It is usually filled with saline and not sterile water in the case of a significant haemothorax. The amount of fluid within this intercostal drain bottle is important. Too little fluid may result in air moving back into the pleural cavity during inspiration, therefore reaccumulating in pneumothorax. In comparison, if there's too much fluid, it can result in increased resistance, therefore making exhalation more difficult, and therefore increasing respiratory effort. So now we've almost completed step 1. We've consented the patient, confirmed the surgical site, we've prepared equipment, and now we should clean, drape and infiltrate local anaesthetic. Some patients may require sedation, however Entonox should be avoided to prevent the re-expansion of a pneumothorax. Step 2, performing the procedure. There's 2 different types, Seldinger and a surgical approach. The Seldinger technique involves inserting a needle into the pleural space whilst aspirating for air. Once confirmed, advance a guide wire and dilate. Conversely, a surgical technique requires incision, blunt dissection with forceps through the intercostal muscles and perform a finger sweep prior to inserting the drain. For pneumothoraces, the goal is to evacuate air from the pleural space, and therefore you would aim to point the drain anterior and superior towards the lung apex, where air collects. Conversely, for pleural effusions or haemothorax, the aim is to drain fluid or blood that settles dependent areas, and therefore aim the drain posterior and anteriorly. Now, once the drain is in position, suture, dress and attach to the underwater seal. Following the chest x-ray, ensure the patient is adequately analgesed and perform a chest x-ray. The chest x-ray should ensure that the proximal holes in the intercostal drain are located inside the pleural cavity. And secondly, to assess the direction of the intercostal drain. It's important to note that in most cases, if the drain is pointing in the wrong direction, it is still likely to be effective, and you would not usually reposition the chest drain based solely on the chest x-ray. Now let's discuss what is swinging and bubbling. This is based on the changes of interpleural pressure. During inspiration for swinging, the interpleural pressure becomes more negative and then fluid rises in the tube. And during expiration becomes less negative and therefore falls. Whilst bubbling, expiration, air escapes from the pleural space by the drain and this causes bubbling within the water. Removing a chest drain should be assessed by a senior medical doctor. Things to consider prior to removal is number 1, has the underlying problem resolved? Number 2, is the lung fully expanded? Number 3, is there minimal drain output? And number 4, is there any air leak? Once a decision has been made, the patient can have the drain removed if clinically indicated. The decision to remove an intercostal drain should be achieved by a senior clinician. Factors to consider prior to removal would be, has the underlying etiology resolved? Are the lungs fully expanded? And is there any air or fluid leak from that drain? Once a decision has been made, the removal procedure is relatively simple. This involves explanation to the patient, positioning the patient, removing the dressings and sutures, and then perform removal of the intercostal chest drain during a Valsalva manoeuvre or expiration with a brisk withdrawal movement. A suture or dressing can be applied. A follow-up chest x-ray should be performed to confirm full lung expansion and the absence of a pneumothorax. In summary, we have discussed the fluid and air indications for insertion of an intercostal drain, the risks associated, the surgical and Seldinger techniques, confirmation of the intercostal drain and when it should be removed. Once again, thank you for watching.